My name is Jacqueline Tamis-Holland, and I'm an interventional cardiologist at the Cleveland Clinic.
Hi, I'm Venu Menon. I'm director of the Cardiac Intensive Care Unit and the Cardiovascular Fellowship Program at the Cleveland Clinic.
We're here to talk to you about our statement, the cardiac cath lab management of the comatose patient with an out-of-hospital cardiac arrest, an AHA consensus document. Unfortunately, out-of-hospital cardiac arrest is not uncommon, occurring in about 350,000 patients each year, and it's a devastating condition in which fewer than 10% survive. The purpose of our document is so we can discuss in more detail and highlight the role of the cardiac cath lab in the management of these patients, because the cardiac cath lab is a critical link in the management. So Venu, tell me about the document. What do you think are the key features?
You know, what I really like about this document is that it's got a unique perspective, and I think the perspective that it really has is from that of an interventional cardiologist. So we know a lot about out-of-hospital cardiac arrest and systems of care that bring a patient into the hospital. We know a lot about the management of patients in the ICU after cardiac arrest. But once they go into the cath lab, it's a little bit of a black box because the decisions that we make are quite complex and they can change from one patient to another. And I think what this document synthesizes is a whole body of evidence that really gives us some sort of a guide as to how we think about these patients when they come into the cath lab in a time-sensitive situation where there's so many challenges that we face. How do you go about setting up the document? How does the document flow, Jacqueline?
Yeah, so we start by talking about the assessment of the patient, and I think that's incredibly key. Just as you pointed out, it's a time-sensitive situation, but you want to be sure you've done a thorough assessment and try to understand what the reason for the arrest is and how best you can help the patient and whether there's a role for the cath lab to help this patient further. And as part of the assessment, I think we really emphasize throughout the document the importance of individualized care. There's many risk factors in assessing somebody with a cardiac arrest, many signs that tell us the potential likelihood for a good outcome. And we really want to individualize care, look at all of the possible factors, and look at the potential risk scores, and then together, put everything together to decide how best to treat our patients.
Now, one of the things that we always struggle with in cardiac arrest has been the neurological devastation that often accompanies these patients. And that's been the constant struggle where we know the benefits of opening up the artery, but those benefits are often not realized because of the hypoxic anoxic encephalopathy that comes up. Does this document really help the clinician in some way think through that situation in an acute emergency?
Yeah, we provide an algorithm and we provide some information about the features that indicate a poor prognosis. But what we really want to do is we really want the clinician to assess the patient in detail, assess them for all of the factors that would indicate potentially a good or a poor outcome, and then really individualize care. We don't give an absolute cutoff or an absolute number to say stop or don't. It's really a matter of every individual patient. So we have this nice sort of figure that, in my opinion, shows you the spectrum of risk. We start with, how was it a witnessed arrest? How long was the patient down before CPR was initiated? Was CPR very good CPR, or was it sort of inadequate from somebody who didn't know how to do it? Was this somebody when they arrive? What is their pH? What is their lactic acid? How old are they? Do they have other comorbidities? And so together, these are all the things we want to think about. And there's really not sort of a set cutoff to say this is futile or this is definitely going to have a great outcome. But together, we want you to individualize care.
So it sounds like a really practical document for the practicing clinician by the bedside to make these challenging decisions that we're faced with every day. Now, do we talk anything about the patients in shock? Because from what I've seen in most documents, especially the data coming out with Jake Genzer at Mayo, when you take a look at the SKY staging, significant number of them appear to have shock. And if you have shock in the setting of arrest, the mortality is bad to start with, but in those patients, it's abysmal.
Yeah, I think it's really hard because you try to incorporate the clinical trials, looking at the data for the role of the cath lab in shock. And then you also have to understand that many of these clinical trials enrolled some patients with cardiac arrest who were comatose, but not all patients. So we want to extrapolate the clinical trial results to this population, which may not always be applicable. You tell me, like, what do you think about these clinical trials? We discuss them in the document. What do you think the role of hemodynamic support in somebody with an arrest who has cardiogenic shock?
I think there's no doubt that these mechanical circulatory support devices provide the hemodynamic support that and it's pretty reliable. But at the end of the day, we simply haven't moved the needle. I can't quote you any data that these devices actually have transformed mortality. But they do give us an opportunity to stabilize the patient. And so in the absence of any further data, our feeling is that patients in arrest should be treated similarly to other people with cardiogenic shock. And the best thing is there are a number of clinical trials in that space that will hopefully highlight for us what the true benefits of MCS support is in this population. Now, the other area, in contrast, where I think there's a whole lot of data, is the non-ST elevation MI patient, right? For years, we just took all acute myocardial infarctions, and we didn't have much data, but we said the cath lab was pivotal in their management. But we've really learned a lot about the non-ST elevation MI cardiac arrest these past few years.
Yeah, absolutely. And in fact, one of our authors is one of the lead investigators for one of those trials, Dr. Carl Kern. And we talk in detail about that. And I think that there's very little data to support having to take everybody emergently to the cath lab simply because they had a cardiac arrest for the purposes of seeing if you have a culprit lesion and opening that culprit lesion. And we talk about those trials in detail. We sort of give examples of the patients that were enrolled in these trials. But I think the other side of it is again, we emphasize the need to think outside the box and not extrapolate every cardiac arrest patient to these clinical trials. So if somebody's with ongoing electrical activity or unstable in shock, then they wouldn't have made the criteria for being enrolled in these trials. And these are some patients that may derive a benefit from going to the cath lab, even if they don't have ST segment elevation. So I think it's a really nice overview of these trials.
You did mention one of our co-authors led one of those trials. Another one of our co-authors is a leader in eCPR.
Yep.
And now we've got 3 clinical trials in eCPR. The number of patients with VA ECMO or getting eCPR has increased dramatically over the past decade. And I think we try to provide some guidance as to what the data is with eCPR and what it takes if you wanted to even start an eCPR program. What insights do we share in this document about that?
There's 3 trials, as you said, and I think what we do is we just provide some information about the 3 trials, and then the 3 trials gave different results. One trial showed a clearly positive result from eCPR. One trial was somewhat positive, trend towards a better outcome, and certainly a better longer-term outcome, although it didn't reach the primary endpoint. And the 3rd trial did not show a benefit to eCPR. So what we do in our document is we talk about the 3 trials, and then we talk about the differences in the enrollment and the way these patients were treated. And I think when you look at the overall results of the 3 trials, you can see that in communities, in observational studies, in communities and in the randomized trials in which eCPR was done in a very systems of care coordinated fashion, there was success. So the 2 trials that did show some benefit were trials in which there was a single hospital doing eCPR. They were experienced in eCPR. There was an integrated relationship between the emergency medical services and the hospitals. And the time to cannulation was pretty early. The initiation of cannulation was within 15 minutes in these trials. On the other hand, in the Inception trial, which was an outstanding trial, and congratulations to the authors, they didn't show a benefit, and it did seem that there was a longer time in the field and a longer time to initiation of eCPR. So I think that those are the things that we want to consider. I think that in communities who are considering eCPR, We want to be sure that there's a coordinated system, that EMS and the hospitals have a very close relationship. There's a decision or an algorithm pathway in which perhaps after 3 shocks or 15 minutes of CPR, if you're in refractory ventricular fibrillation or tachycardia, that you then begin the initiation of transfer to an ECMO-capable center so you can give ECMO. And that's what our document discusses in more detail.
Yeah, I think that's really important, right? Because obviously it's a new kid on the block. It's an exciting thing to do. There's some supportive data, but we're not so sure. I think it's so important to do this responsibly if you're going to be doing it, to measure and report your outcomes, because while it's promising, we still haven't been able to extrapolate it in the community setting. And so I think how this strategy is going to evolve in the next few years is going to be fascinating. Like most statements, is there an angle on research gaps that we focus on in this statement too?
I think one of the things is that we do talk a lot about risk scores in cardiac arrest, but we emphasize that there really is no prospective data showing that the utilization of the risk scores up front and to determine management has been done. So we can use the risk scores, but it should be part of our risk assessment. It shouldn't be everything. So we talk about a gap in knowledge in terms of, is there a role for using a risk score to determine the treatment? And right now, we don't have any data on that prospectively. And we talk about more about the role of eCPR in patients and, in more clinical trials to understand this better and the group of patients that may benefit, or the things that are needed for communities to implement eCPR.
Now, I work in the ICU, and so I was initially interested in the post-ICU care of these patients, but very appropriately, we don't really discuss the management post-ICU care in this document. It's really important as part of the systems of care approach and the link of survival, but we refer the audience to other fantastic documents from the AHA and the ACC that deal with this kind of stuff and really confine ourselves to the cath lab. So in many ways, this is a very niche document, really focusing on the thought process of what needs to go into the lab and what our decisions in the lab are. What I really liked was we even go and talk about topics that are not often discussed. Pulmonary embolism is one of them.
I think we would all agree that there are not so many patients that are going to the cath lab for pulmonary embolism, and in many hospitals, they take them to the interventional suite. But we do sort of indicate that there are some patients with contraindications to lytic or refractory shock that might need the cath lab for either VA ECMO or for catheter-directed thrombolysis. And these are the patients in which the cath lab may be indicated because the interventional suites may not be ideally suited to handle such a critically ill patient.
So overall, I enjoyed working with you on this document. I think it really fulfills a niche that hasn't been addressed. I'm hoping that the readership, when they get to review this, are really able in their day-to-day decisions to take consideration of the evidence base. And I think what I really like a lot is that the practice of medicine is never perfect. We do have a body of evidence, but it's hard to translate that into decisions by the bedside. And I think what I enjoyed with reading this paper and being part of it is that I learned the thought process and the rigor and the consistency as to how to respond to these unfortunate challenges that come at odd hours, stress the system, stress the individual, and are associated with very poor outcomes, but in whom every patient is important, and we have to really individualize the management. Would you think that's the highlights of the paper?
Absolutely. I think that the key features are the individualized care, the rapid assessment, and really the systems of care approach, which is sort of the cardiac cath lab is one part of the chain of survival in cardiac arrest.
So I had a great time working on this paper, and Jacqueline, I think you were a terrific leader, corralling all of us to get these documents in on time and putting this document together. I think I was able to influence Jacqueline a little bit when we started. She was a cardiologist in New York City, and now she happens to be a colleague in Cleveland. So welcome to the Midwest, Jacqueline.
I'd like to thank Venu for being vice chair of this document and for all your leadership on this document, and all of our co-authors. But most important of all, I'd like to thank the American Heart Association for commissioning this document and allowing us to bring it to you. We hope you enjoy it.